This is the fourth year that we are doing the LMLR online, and today will be the last of our webinar series for this year, the finale for this year. So as you know, the LMLR aims to teach rheumatology to healthcare professionals, an advocacy initiated by Dr. Lourdes Manahan, the first Filipino rheumatologist. And speaking of advocacy, we'd like to greet one of our original mentors and a pillar of Philippine rheumatology, Dr. Clemente Amante. Happy birthday, sir. This year's theme is Life to the Max, Living with Rheumatic Diseases. We wish to emphasize a holistic understanding of our patients and their diseases, as well as strategies through which we can make our patients' lives better. LMLR is in support of the WHO Sustainable Development Goal number 3 on health and well-being and number 4 on quality education. The Division of Rheumatology has its books, the Atlas of Rheumatology, the Atlas of Rheumatic Diseases in the Philippines, and the Physician's Guide to Telerheumatology, which is intended for use for both telemedicine and face-to-face consultations. So for those who wish to purchase copies of our books, you can do so by contacting our email. Our lectures for today will focus on how to differentiate osteoarthritis from other causes of joint and back pain in older persons, and to talk about the management of these conditions. We will also see very interesting new research on musculoskeletal and associated disorders in older persons in the Philippine setting. Ultimately, we wish to increase the awareness about the special concerns of older persons that may affect the management of musculoskeletal diseases. We are deeply honored to have two distinguished speakers. Both are undeniably excellent in their respective fields. Our first speaker is Dr. Allan Corpuz. Dr. Corpuz completed his residency training in internal medicine and his fellowship training in rheumatology in UPPGH. He's the head of the Division of Rheumatology and the Hospital Research Unit in Ilocos Training and Regional Medical Center. He is also affiliated in several hospitals such as the Lorma Medical Center, Bethany Hospital, and La Union Medical and Diagnostic Center. Our second speaker is Dr. Shelley De la Vega. She completed her residency training in internal medicine in State University of New York, downstate Brooklyn, and her fellowship training in geriatric in Harvard Medical School. She also had her master's in clinical epidemiology in University of the Philippines, Manila, and is a current Professor 9 in College of Medicine and a director of the Institute of Aging of the National Institute of Health in UP Manila. She's the past president of the Philippine College of Geriatric Medicine and also the Philippine Foundation for Vaccination. She's currently affiliated in the Medical City and the Philippine General Hospital. So, ladies and gentlemen, without further ado, let us welcome Dr. Allan Corpuz and Dr. Shelley De la Vega as they share their expertise in today's topics.
Good morning, everyone, and welcome to the 20th Lourdes A. Manahan Lectures in Rheumatology. This morning, we will be navigating joint and back pain conditions in the 50-something patient. My first exposure to the LMLR was in 2007 as an intern at the Ilocos Training and Regional Medical Center. I listened as Professors Esther Penserga, Evelyn Salido, and Hazel Reyes came over my hometown in San Fernando, La Union to talk about the concept of GALS, or the gait, arms, leg, and spine, which was a rapid way to assess musculoskeletal conditions. Although I was only there for half the experience, it opened my eyes to the fundamental nature of rheumatology as a specialty and the beauty of making a diagnosis without the bells and whistles of technology. And I think that is what Dr. Manahan was all about, being a fundamental clinician, and it showed in those three passionate teachers who have eventually become my mentors. 16 years later, it has come full circle, and now I pay it forward to all the students of rheumatology as a thank you to my teachers. To the division, I appreciate this opportunity. The feeling is surreal, and I pray that I will be able to spark an appreciation of the specialty, just like you all did for me in 2007. This will be our roadmap to today's presentation. There are two objectives. One is to differentiate osteoarthritis from other causes of back and joint pain in the older person, and to discuss basic principles in the medical treatment of these conditions. There's a booming senior citizen population in the Philippines, and a lot of them would have musculoskeletal conditions. Majority would be back pain, with those who are older having chronic back pain lasting more than 3 months. However, back pain and joint pain is usually undertreated in older adults, with less than half of primary care physicians having strong confidence in diagnosing the causes of chronic low back pain in older adults, which results to over-reliance on medical imaging and improper management, or usually under treatment. In the Philippines, the women and elderly usually report chronic pain conditions, with the knees, back, and lower back being the most common locations. 60% were not able to ask advice due to high cost of medical care, while majority reported taking prescription painkillers that were less than effective. The following are the physical, individual, and psychosocial and organizational factors that affect the occurrence of back pain. Distinguishing the signs and symptoms of nociceptive pain or mechanical pain from neuropathic pain or radicular pain is an essential first step in diagnosis of back pain. Usually, when patients come to the clinic, just try to listen to them without ordering any tests, and you'll be able to differentiate the type of pain that they're experiencing. For nerve pain, usually they will use indicators such as tingling, numbness, pins and needle sensation, a warm or cold sensation that flows down the leg, a weird feeling that is hard to describe, a type of pain that changes from minute to minute or from hour to hour. Usually, the type of pain would be something that radiates below the knee down to the ankle, as only nerve pain can send signals that far unless it's a circulation problem. This is usually due to disc problem or to nerve impingement problem. So the gold standard here would be to do a straight leg raise test where you ask the patient to lie supine, elevate the leg to 60 degrees, dorsiflex the foot, and lift the head up. And if there's a shooting pain from the buttocks down to the legs, then you know that that's nerve impingement. Alternatively, if you do not have any bed in your examining room, or if the patient is not capable of lying down, then you can do the slump test where you ask the patient to sit down, slump over, bend the head down, extend the leg, and dorsiflex the foot. And usually, when you reproduce a pain that radiates from the buttocks down to the leg, then you know that it's a neuropathic pain. For joint pains, usually the pain is more localized. So you ask the patient to do flexion of the spine. When you do lumbar flexion, you actually spread apart the joints. And when you do lumbar extension, you are jamming the joints together, facet joints together. So usually, patients with facet joint arthritis would lean away from the painful side. So if it's a unilateral facet joint arthritis, for example, on the left, they would tend to lean more to the right side to open up the joint. For sacroiliac joint pain and hip pain, there's a sharp pain that happens when you jump or when a patient does not anticipate a fall from a curb. So this type of pain does not refer past the knee, but can refer to the knee. There's no numbness or tingling here. It's just pain or an aching type of pain. Here you can do a figure of 4 test where you can ask the patient to lie down and cross the leg, or ask the patient who is seated to cross the leg. And if there's pain on the hip area, then you know it's a sacroiliac joint or a hip problem. You can also do the point test where you ask a patient to point to the area of pain, mark the area, and then ask the patient to repeat it again. And if the patient is able to consistently point to the same area, then you know that it's a sacroiliac joint problem. For muscle strain, the pain is usually localized and is not referred down to the leg or the foot. So here you ask the patient to lie down prone, and then you palpate the paraspinal muscles and look for knots or point tenderness. So if you can reproduce tenderness, or if you can palpate the knots, then you know that it's a muscle strain. It can also be classified by duration, with chronic back pain being defined as lasting more than 12 weeks and chronic joint pain being defined more than 6 weeks. And finally, you can classify it by etiology. We have mechanical, degenerative, inflammatory, infectious, and oncologic etiologies. It is important to fleece out in the history and PE possible red flags in joint and back pain to rule out malignancy, infection, fracture, and neurologic compromise, as this can increase a patient's morbidity and possibly mortality. Now let's go through the most common joint and back pain conditions experienced by patients who are more than 50 years old. Again, for lumbosacral muscle strains, sprains, and myofascial pain syndrome, there's tenderness to palpation of the muscles, and this usually follows a traumatic incident or repetitive overuse. Sometimes something as simple as staying on your computer or on your keyboard for half a day or an entire day, or cleaning the house or washing the laundry can trigger this type of pain. The pain is localized at the lumbar region or the thigh, or can also be found in the shoulder area. As mentioned earlier, sacroiliac joint disorders is most intense when sitting or lying on one side, and there's pain in the buttocks and the lower back, which is aggravated by trunk extension. So we ask the patient to bend backward, ipsilateral lateral flexion, and or rotation. The pain can be burning sharp, or it can present with numbness that radiates to the groin, the back of the thigh, or the outer side of the thigh. The difference with radiculopathy is that this type of pain does not extend below the knee. So activities that involve the sacroiliac joint, such as bending at the waist when tying their shoes or putting on their shoes or their socks, stair climbing, or asymmetric activities such as lifting a weight with one arm, like carrying their apos or their groceries, can provoke an increase in pain. For spondylolysis or spondylolisthesis, the back pain radiates to the buttocks and the posterior thighs, and usually the radiculopathy would be in an L5 distribution. This is common among women who are 60 years old and above, and is usually associated with facet hypertrophy. Cauda-Equina syndrome is a medical emergency that requires decompression. Patients may or may not experience sciatica depending on the location of the nerve root compression. They will have bowel, bladder, or sexual dysfunction, as well as perianal numbness. And this is usually caused by central disc herniation, lower lumbar spondylolisthesis, spinal tumors, dislocated fractures, or abscesses within the spinal canals. A patient with a fracture will have significant trauma relative to age. Usually, they can have prolonged history of corticosteroid use, osteoporosis, or are above 70 years old. You'll be able to appreciate contusions, abrasions, and tenderness to palpation over the area of the fracture. This is why when the patient complains of low back pain, you do not restrict your imaging to a lumbosacral vertebra AP lateral view, but also do a hip AP view. For degenerative etiologies, you have your facet joint syndrome or your facet joint arthritis, where the pain is localized to the lower back with or without posterior thigh pain, especially during walking. So the characteristic type of pain here is that it is most intense early in the morning when they wake up. It improves during the day and again recurs at the end of the day. It can interrupt sleep, and it can be aching and steady or intermittent. Usually when you do palpation, there's localized tenderness on the affected area of the spine. And you can reproduce the pain by asking the patient to do trunk extension, ipsilateral lateral flexion, and or rotation. So you ask the patient to bend backward or to do lateral flexion and rotate the back. Contrast this with degenerative disc disease, where the pain radiates distal to the knee. So these patients can also have back pain, but usually there's radiation distal to the knee. They will have indicators such as paresthesia, numbness, and tingling, and the straight leg raise would be characteristically positive in these cases. The reflexes can also be impaired, and there can be weakness and sensory loss. Spinal stenosis would present with severe leg pain that is absent when the patient is seated. So this patient would have pseudoclaudication, they can have a wide-based gait, and they can assume a hunched posture as if they're pushing a shopping cart. That's why sometimes we call it the shopping cart sign. So this is because the pain is eased when they are sitting or when they are in a forward-leaning position. This is uncommon in patients who are less than 50 years old. Osteoporosis with or without vertebral compression fractures will usually complain of a kyphotic posture or a loss of height. So sabihin nila, parang lumiliit yata ako and nakukuba ako. These patients would have worse pain when they are standing or walking, and they will have partial pain relief when lying down on the back. So on physical examination, you'll be able to appreciate localized back pain, and this is worse when the patient flexes, in contrast to your spinal stenosis, and there's point tenderness on palpation if there's a vertebral fracture. Hip osteoarthritis would be pain in the buttocks, the groin, or anterior thigh, and occasionally it can radiate down to the knee. So it can resemble an L2 or L3 radiculopathy. Again, the way to differentiate this with disc herniation would be that there's no radiation distal to the knee area. You can elicit the pain by asking the patient to cross the leg or to do internal or external rotation of the hip. Radiographics can be confirmatory. It will show joint space narrowing, the presence of osteophytes, and subcondylar sclerosis. Scoliosis in adults usually are not painful. However, adults who are aware that they have scoliosis based on an X-ray would be reporting more symptoms of pain or discomfort, even if it's not typically associated with the scoliosis. Therefore, the provider should rule out other causes before attributing the pain to scoliosis. This is usually an incidental diagnosis in radiographs which were done for other indications. So it's usually an asymptomatic problem seen in elderly patients with diabetes, but if there's a presenting symptom, it would be stiffness of the back. And occasionally, there could be dysphagia, hoarseness, or stridor. The X-rays would reveal the characteristic candle wax dripping appearance, which is a flowing anterior calcification on at least 4 contiguous vertebrae. In contrast to your ankylosing spondylitis, the sacroiliac joints are not involved here. The disc height is preserved, and the acute phase reactance, or your ESR and CRP, are normal. Inflammatory etiologies, the most important one here, I think, would be ankylosing spondylitis. So the history would date back to before the patient was before 40 years old. Usually, it has a gradual onset, and the morning stiffness would be very severe, lasting more than 30 minutes. And the characteristic pain here is that it improves with exercise, or they do better when they move around, and worsens with rest, or they are more stiff when they're lying down or seated. The pain lasts for more than 3 months and is not relieved when the patient is supine. There can be alternating bout of pain, and the pain is worse at the second half of the night. So sa madaling araw, masakit talaga siya. Characteristically also, this has very good response to NSAIDs. And when NSAIDs are withheld or stopped, the pain immediately recurs. The spinal range of motion that is decreased, or the hunch posture that you see on the screen, is seen in the more advanced stages of the disease. And hopefully, we get patients before they become hunched, like the one in the picture. PMR is a sudden onset of pain, stiffness of the neck, upper back, the shoulders, the lower back, the buttocks, and the hips in a patient who is more than 4 years old. And usually the history is it happened within 2 weeks. It's more common in women. If you do an acute phase reactant test, the ESR would be elevated to more than 40 millimeters per hour. So because it's a polyarticular presentation, or multiple joints are involved, you should test for the rheumatoid factor. It's usually negative, or the ACPA, or the anti-citrullinated peptide antibodies, are also negative. Characteristically, this has dramatic response to steroids, and in 40% of patients, giant cell arteritis can coexist. Trochanteric bursitis is an aching pain on the lateral side of the hip, and in 40% of patients, it can extend down the lateral aspect of the thigh, so that the patients will have difficulty lying on the affected side because of the pain. And here, just palpate over the greater trochanter, and there will be direct tenderness. You can also do forced hip abduction, and this will reproduce the pain as well. Rheumatoid arthritis, the characteristic finding here would be asymmetric polyarthritis. And in the more advanced stages of the disease, you can see joint deformities. If the cervical spine is involved, you can have neck pain and occipital headache. So this will have a positive Lhermitte sign, and the neck stiffness is perceived throughout the entire arc of motion. So this is a polyarthritis, meaning more than 3 joints are involved. There's swelling, there's inflammation, and there can be extra-articular manifestations. Gout will present with episodic arthritis. So in contrast to all the other conditions that we discussed earlier, this one is episodes. It comes in bursts. It usually starts as a monoarthritis, so pain on the first MTP, or metatarsophalangeal joint, or the foot and the ankle in the early course of the disease, and then eventually becomes oligoarticular and polyarticular in the later stages of the disease, especially when it's untreated. Tophi may or may not be seen. If there's tophi, then you know that the disease is already chronic. And during a flare, there's joint tenderness and or swelling. The uric acid may or may not be elevated, and in 50% of the time during a flare, the uric acid may be normal. It rarely affects the spine, but when it does, the back pain is usually due to changes in gait and posture due to the flare. The spinal tophi can be there occasionally, rarely. And when they do, they can mimic other conditions such as epidural abscess, spondylodiscitis, and neoplasms. Intra-abdominal visceral diseases such as ulcers or pancreatitis or kidney stones, or infections such as pyelonephritis, prostatitis, or pelvic infections, and vascular problems such as aortic dissection can all present with back pain also. Infectious conditions such as your vertebral osteomyelitis and your pyogenic spondylodiscitis and spinal abscesses or epidural abscesses will present with fever and low back pain. So there's localized tenderness on palpation of the spine. This usually have a history of a long-standing disease such as uncontrolled diabetes, HIV, chronic kidney disease on dialysis, liver cirrhosis, infectious endocarditis, malignancies, or autoimmune diseases. They can be osteoporotic. They can have a past history of trauma, recurrent UTI, history of intravenous drug use. So the elevations of PSR and CRP are also key here, and there's paraspinal muscle spasm. In tuberculous osteomyelitis, you may appreciate a groin mass due to an abscess in the psoas muscle. It's also very important that when the patient complains of back pain, especially on the buttocks, that you expose the area of the pain, of course, with permission from your patient, because herpes zoster may be the problem here. So sometimes we can assume that when the patient complains of back pain or buttock pain, then it's sciatica or piriformis syndrome or a nerve impingement. When in fact, when you open up the area, you'll be able to find a unilateral dermatomal rash, which is characteristic of herpes zoster. So oncologic problems are usually from metastatic disease, from the prostate, breast, and lung. It's more common in patients who are more than 50 years old. You can appreciate focal or localized tenderness, and the typical type of pain here would be an unremitting, progressive, localized or radiating pain that is aggravated by movement, that is not relieved by rest, and is worse at night. Usually, patients would have progressive weight loss or other cancer symptoms. For patients with psychosocial distress, your physical examination and maybe even your history will not follow a clear clinical or anatomical pattern. Usually, these patients would have visible emotional or psychological distress, and they would repeatedly come to the clinic with the same complaints and do not improve with any interventions, resulting in delayed recovery, chronic pain, and poor functional outcomes. Menopause can also be a cause of joint and back pain. In the history, you'll find amenorrhea or oligomenorrhea with headache, mood swings, hot flashes, fatigue, night sweats, and myalgia and arthralgia that is described as dull, aching, or a shooting sensation with stiffness that is worse in the morning. Fibromyalgia is one of the more challenging rheumatologic conditions to diagnose and treat. It has a dull, aching, flu-like type of pain. There's usually psychological distress. Patients would report non-restorative or disrupted sleep and fatigue. And it has a characteristic widespread type of pain, and there's tenderness in 11 out of the 18 defined points. So when is imaging warranted for back pain or joint pain? Let us try to avoid being victims of medical imaging technology. And the reason for this is that radiographic exams are usually of limited use unless the history or P suggests a specific underlying cause. There is weak association between imaging abnormalities and symptoms, and the problem with early imaging or imaging without correlating the symptoms would be it would reinforce suspicion of serious disease. It can magnify the importance of non-specific findings commonly, and it can label the patients with spurious diagnosis. So although spinal degenerative changes may induce back pain, not all anomalies that you will see on your radiographs or your MRIs are related to low back pain, because abnormal imaging phenotypes are ubiquitous among asymptomatic older adults. In fact, in this systematic literature review of imaging features of spinal degeneration in asymptomatic patients, even as early as 20 years old, you'll be able to find a lot of these disc problems or facet degeneration, as disc herniation is prevalent even in pain-free individuals. Therefore, this emphasizes that the demonstration of an anatomic abnormality should not automatically lead you to assume that it is the cause of pain. And the problem with earlier imaging for back pain or joint pains without associated symptoms is that it does not lead to improved outcomes, but only increases medical costs and the use of invasive procedures. Therefore, imaging is not required unless significant symptoms persist beyond 6 to 8 weeks. However, imaging is useful if there's suspicion for an underlying serious disease that will require surgical or other interventions. What about other diagnostic tests? Usually, an elevated ESR or CRP would make you think of a systemic problem such as an infection, malignancy, or autoimmune or inflammatory process. And in these cases, if it's elevated, then you can test further as necessary. The EMG NCV can also be considered useful to assess myelopathy, radiculopathy, neuropathy, and myopathy. However, if the symptom duration is less than 4 weeks, then it can also be unreliable. Let's go through an overview of treatment of joint and back pain in the elderly. Let's start with fall prevention and addressing osteoporosis. So you can tell your patients the following, or you can instruct the caregivers the following. So instruct the patient to wear non-slip shoes and set up the house so that there are handrails on the stairs and in the shower. Remove tripping hazards such as power cords, stones around the garden, and then encourage the patient to do aerobic exercises at least 3 hours per week, either by using a stationary bike or doing water exercises or walking or jogging or tai chi. Also, encourage them to walk at least 1 hour per week, and this 1 hour can already be included in the minimum 3-hour exercise per week. And a habitually brisk walking speed of 3 miles per hour is more protective against a fall than a generally slow walking pace. In patients who are more than 65 years old or who have significant risk factors, screen for osteoporosis and treat accordingly with bisphosphonates, denosumab, or teriparatide, depending on your discussion with the patient. With the use of pain medications, always consider the etiology of the pain first, and always evaluate hepatic and renal function first. If you're unsure, use a kidney-friendly drug or use the lowest dose of medications while awaiting the test. About as-needed tests or round-the-clock or standing order tests. For older patients with chronic pain, a standing order of analgesic is usually recommended so that they can have a steady concentration of analgesic in the bloodstream. Also, inflammatory conditions such as ankylosing spondylitis, rheumatoid arthritis, and polymyalgia rheumatica require continuous medications to control the inflammation. With regards to opioid versus NSAIDs, you have to consider the need for anti-inflammatory medications. So opioids do not have an anti-inflammatory effect, while NSAIDs, of course, obviously have. So always consider also comorbid conditions such as GI, cardiac, renal, neurologic, and hepatic disorders, which may interfere with the metabolism of your medications. Use NSAIDs as an adjunctive therapy if the condition is non-inflammatory or as a primary therapy for inflammatory conditions, as long as you have a normal kidney function. Add a proton pump inhibitor if there's a risk for developing gastrointestinal bleeding. Use NSAIDs with caution in patients with hypertension and heart failure, and always watch out for drug-to-drug interactions. Muscle relaxants, gabapentin and pregabalin, duloxetine, topical analgesics, and opioids can be used on a case-by-case basis. You can actually combine these drugs while watching out for potential adverse events like nausea, dizziness, behavioral changes, vomiting. And also, the dictum is to start low and go slow with the doses. You can use 2 or more pain medications with different mechanisms of action or different drug classes to be able to attain better pain relief with minimal side effects rather than relying on a single drug with higher doses. So usually you can combine NSAIDs and opioids, NSAIDs and muscle relaxants, or NSAIDs and pregabalin. However, try not to combine NSAIDs and steroids when dealing with pain, as this can increase the risk for gastrointestinal bleeding. The use of conventional synthetic DMARDs and or biologic DMARDs may be recommended early in the course of the disease in patients with ankylosing spondylitis and rheumatoid arthritis. And in patients with polymyalgia rheumatica, rheumatoid arthritis, and gout with chronic kidney disease who cannot use NSAIDs, the use of steroids may be warranted. Most cases of back pain are mechanical in origin and respond to activity modification, rise, ice, and heat, and physical therapy and core strengthening exercises can also play a role. Most effective among this would be the McKenzie method, and other integrative modalities such as acupuncture, tai chi, and yoga have also been shown to have a moderate effect on the improvement of back pain. So you can teach the patients the following. They can do movement around the swimming pool or at the beach. They can do lumbar stabilization exercises like a hamstring stretch using a bed as long as they're supervised. Or they can do core strengthening exercises as follows in order to improve stability, posture, and steadiness while walking. Lumbar surgery can either be decompression, spinal fusion, or disc arthroplasty. And for patients who do not want to undergo surgery or who have contraindications to undergoing surgery, then corticosteroid injections, radiofrequency ablative therapy, and spinal cord stimulators and TENS units are possible treatment options. So, to summarize, a good history and PE, examination of red flags, and differentiation of neuropathic versus nociceptive pain from the start is usually more than enough in evaluating joint and back pain in the elderly patient. Try to avoid imaging before 6 weeks in severe pain in the absence of red flags, and only do imaging early in the course of the disease or refer or treat aggressively if there's the presence of red flags. You should address all comorbidities, especially for refractory back pain and those with red flags on presentation. For as needed versus RTC pain control, consider RTC, especially for patients with chronic inflammatory conditions and in patients with cognitive disorders and those who cannot verbalize their pain, while at the same time considering safety and comorbidities. You can combine different interventions when treating back pain or joint pain to maximize the different mechanisms of actions of these drugs. Consider an interprofessional approach or a multidisciplinary approach for a holistic treatment plan in order to avoid duplication of treatment and tests and to deliver the same message to a patient. Reserve surgery for refractory cases and inform patients of the risks and benefits and possible alternatives if they do not consent to surgery. To end, let me tell you a story about the French impressionist Auguste Renoir, who was confined to his home during the last decade of his life. He had a friend named Henri Matisse, who was 28 younger than him, and they were very close with each other and they were frequent companions. Renoir was almost paralyzed at this time of his life, but he continued to paint in spite of his infirmities. And one day, as Matisse was watching the elder painter working in his studio, trying to fight off the pain with each brushstroke, he blurted, "Auguste, why do you continue to paint when you are in such agony?" And Renoir replied, "The pain passes, but the beauty remains." I hope that as medical practitioners and caregivers of our patient, we will be able to diagnose and treat them properly so that the pain would pass and the beauty of their golden years would remain. Thank you for your attention. We'll try to answer your questions later. And for those whose questions will not be tackled, you can email them to me. You can also view the slide deck at slideshare.net. Thank you again and good morning.
Si Marita Villare Adona, 55 years old. Economically, napakahirap kasi hindi na ako makapagtrabaho. Then, pag sumumpong ang mga joints ko, talagang nakahiga lang ako. Tapos, hindi ako makapagnegosyo kahit gustuhin ko man kasi hindi ako makakilos ng ayos. Tapos, sa aming mag-asawa, bali, nahihirapan din siya kasi pagka sumumpong ang joints ko, hindi siya makapagtrabaho din. Tricycle driver po siya. Binabantayan niya ako. Ang hirap lang talaga financially. Kasi kahit gusto kong kumilos, nahihirapan po talaga.
Ayan po naging epekto sa likod ko. May mga karamdaman po na katulad sa mga buto. Saka apektado na po pang anak buhay ko. Kaya di pa ako nakapasok ng trabaho.
Minsan nahirapan po ako kumilos-kilos. Tapos nanghihina po yung katawan ko.
Hindi na ako makakilos, hindi na ako makagalaw. Pati asawa ko, pamilyang apektado sa akin kasi nga, inaakay nila ako. Minsan, pati pangungubeta ko, talaga tinutulungan pa ako. Kasi hindi ako makano, yung kamay ko, pagka namamagayan. Yung asawa ko pa nag-ano ng dumi ko. Kaya napakahirap ng arthritis. Na hanggang ngayon, bit-bit ko, dala ko yung pain. Yung pain, lalo sa tuhod. Ngayon, 61 na ako. Ang hirap ng karamdamang arthritis. Napakahirap. Napakahirap ng karamdaman sa buto. Hindi ako ganito dati, mabilis ako kumilos. Pero dahil dito, talagang pinababagal niya lahat. Mabagal ang panahon, mabagal lahat. Dahil mabagal ang galaw eh.
Morning. Shall I start now?
Yes, ma'am, please proceed. Thank you.
Okay. Good morning, everyone. I'm Dr. Shelley De la Vega, and I'm so happy that Dr. Allan Corpuz presented a very extensive discussion of the differential diagnosis of joint and back pain, especially among older adults. And I hope that my talk will complement what he presented, because I'm going to present for the first time many of the data that we have gathered in three separate researches using the comprehensive geriatric assessment, and specifically to talk about pain and rheumatological conditions. So this is part 2 of when you're 50 and having joint and back pains. So these are my disclosures. I have no pharmaceutical employment, and I'm not a speaker or advisor for any industry. So the objectives of this talk are to identify, first, using up-to-date pearls for the assessment of chronic back pain in the older patient, to describe the experience of pain and arthritis of community-dwelling Filipinos aged 60 and older in 3 separate studies, to present data on osteoarthritis reported by older people versus geriatrician-diagnosed arthritis, to present data on medication and supplement use and alternative therapy use among our cohort of patients, and to present data on the associated problems such as falls and frailty. And I'm so glad that Dr. Allan talked about environmental modification, because I will present how our participants feel about their home environment and the hospitals and clinics where they go to. So let's just very simply go through what UpToDate says about chronic back pain. So UpToDate is an app, right? It concisely brings together all updated evidence on certain medical conditions. And this time, going to the 2023 advisory on chronic back pain, they define chronic back pain as pain duration of more than 3 months. And in that app, it says that in the assessment of chronic back pain in the old, accurate and comprehensive history is needed. That's why I'm going to present to you 3 research projects using the comprehensive geriatric assessment, because it's not simple. to assess back pain among older people, with the goal, of course, of maximizing function and quality of life. And it also says that we need to avoid treatment toxicity. And I think Dr. Allan has already elucidated some of these. First, to use non-pharmacological treatments, and then to choose drugs with the lowest side effects that are least toxic and the lowest potential for drug interaction. Specifically, local agents are advised, and then, of course, to avoid opioid drugs. So non-opioid drugs are recommended. So personally, I give acetaminophen first for regular degenerative arthritis for our older patients. So now let's go to the Fit for Frail study that I mentioned earlier. So the Fit for Frail study is a study on community dwelling Filipinos aged 60 years and older in 4 select barangays in regions in the NCR, in Region 4A, 7, and 11. And I'm also going to present the UP-wise data, UP Wellness. Again, this also uses the comprehensive geriatric assessment. And we have data from Los Baños, the Los Baños campus, and the Diliman campus of those who are still working and retired, age 60 and older. The main objective of these 3 studies are to describe the health status of older adults and to describe the prevalence of frailty in these select communities using the comprehensive geriatric assessment tool. So we recruited more than 900 actually, and 355 attended the medical exam for the Fit for Frail. This is just the Fit for Frail data, not from UP. And 50 participants, unfortunately, did not complete their CGA or their medical exam. So I'm going to gather now and present to you some of the data from this first study. Physician was the one who made the diagnosis, trained in geriatrics, of course, and there was a senior geriatrician who adjudicated all of the final diagnosis. Okay, so this is the comprehensive geriatric assessment form, physical exam portion that we use both for Fit for Frail and the UPY studies. And if you can see here, there is a visual analog pain scale that we used, and of course a diagram where the patient identifies the location of the pain. So it was very important in this study that we really count and describe the pain that they experience. So what did we find out? We found out that the experience, one of the findings in the Fit for Frail study is that the experience of pain was not always confirmed on physical examination by the physician. So here is the table that we generated. The participants were asked by the geriatrician whether or not they felt any kind of pain in their body. So we didn't really ask if that was chronic pain or no, it was really any kind of pain. So of the 352 participants who responded to the question, the majority reported that they felt no pain. So 63.9% had no pain, while the remaining 36.1% reported some form of pain in their body. Those aged 70 to 79 years old had the highest proportion of participants who reported pain, and the experience of pain was roughly similar between sexes. However, during the physical exam, only 3 people were able to report a pain score of 1/10 or higher. And of the 3 people, 2 participants were from Region 7 and 1 from Region 4A. So therefore, yes, they experienced pain, but when they were already in the presence of a doctor, nawala ang sakit. O siguro wala naman talagang sakit. Kaya nakarating sila sa clinical site. Okay. Our next finding in the study is that self-reported experience of arthritis was underrepresented compared to physician-diagnosed osteoarthritis. So although osteoarthritis is one of the top 5 reported diagnoses, self-reported experience of arthritis was really lower compared to that was generated in the presence of a physician. So this is the table on self-reported illness. If you can see here, arthritis was 13.6% only of that, what that was reported by the patients or the participants. And when they were examined by the geriatrician, about 35.6% pala of them had osteoarthritis. So there was siguro a problem in reporting or an understanding that that was arthritis, di ba? Kasi kung minsan sakit lang, they don't know where it's coming from. So it was osteoarthritis in fit for frail was only second to hypertension in terms of the top 10 geriatrician diagnosed illnesses. Now, looking at the comparison, therefore, of self-reported diagnosis versus geriatrician diagnosis, you can see not a great difference between self-report and diagnosis by a physician. So I'm a little bit worried because sometimes some of our studies checking for prevalence just asks the patient, meron ka ba nitong sakit na to? Diba? May arthritis ka ba? So baka we are undercounting really because unless a physician really diagnosis that gives them the diagnosis, they might not forget or they may not know. So now let's go to the Los Baños cohort. So in Los Baños, we had both working and retired people in the UP campus there, age 60 and older then, no? And osteoarthritis was also part of the top 5 self-reported diagnoses. So it was second again to hypertension. More retired respondents had musculoskeletal problems and more working respondents had nerve problems pa. So I don't know, maybe mahirap pa rin pala magtrabaho, no? So masakit ang katawan nila. So here you can see the distribution of musculoskeletal problems, and more of the retired were experiencing musculoskeletal problems. But pagdating sa sensory, these are yung mga pain, indistinct. You know, we really don't know, is it osteoarthritis kind of pain? But a lot of them did experience some sort of sensory problem when it comes to self-report. Now, in the UP Los Baños cohort, again, we'll note that more of the retired, but also you note that many of the working still, no, were experiencing some sort of musculoskeletal pain. All right. So again, looking at that table in Los Baños cohort, 49% no, had osteoarthritis diagnosed by the geriatrician. And it was top 2, second only to hypertension. Okay. Now, let's go to, this is just another way of reporting it, of interest, no? Aside from osteoporosis, we were able to do some blood tests. And at the bottom there of that chart, you will see of interest that almost 90% of those in Los Baños had vitamin D insufficiency. So I don't know if that truly contributes to arthritis pain, but I know that some of my patients say that when they were experiencing joint pain, especially during the pandemic, and they had their vitamin D tested, those who had low vitamin D were attributing their joint and back pains from low vitamin D. And when they started taking vitamin D, nawala daw ang mga joint pain. So maybe it's true, no? Okay, so let's now go to Diliman. So Diliman was another cohort. Again, 60 and older, working and retired. Again, CGA reported that osteoarthritis was again in the top 5. Again, only second to hypertension. So almost the same as the Los Baños cohort. But here, when we looked at their laboratory tests and included that in the overall list of problems, no, you can see that number 4 there is hyperuricemia. So hyperuricemia, number 4, ang taas pala, no? And maybe they didn't understand that it was gout, or maybe it was hyperuricemia, not necessarily from gout. But it's very interesting to note that number 4 of the top 5 geriatrician diagnosis was hyperuricemia, because we had lab tests done in this study. So now let's go to the drugs that they're taking. I know that Dr. Corpuz mentioned several drugs that had to be of priority. And if you look here in the next slide, we will realize that, yes, no, our patients in the Fit for Frail study were using a lot of musculoskeletal related drugs or drugs for their musculoskeletal system. And there's a little bit of data that says that maybe they're not so much into alternative treatment. So, okay, so let's look at this table, and we can see here that the number 3, 14.3% of our participants were using musculoskeletal system drugs or drugs for their painful joints and muscles. And that was third only compared to cardiovascular and alimentary tract or GI tract drugs. And tie sila ng blood and blood-forming drugs such as ferrous sulfate. So in that study also, we found out that 82% of them took some form of medication and 28.4% took food supplements, almost similar in distribution by sex and age groups. And the most commonly taken supplements were mangosteen and turmeric. Now, I'm not so sure about mangosteen, but I know that turmeric is being promoted as an anti-inflammatory supplement. And I think many of our participants and many of my patients currently also take turmeric for arthritis symptoms, di ba? Okay, so that is what we learned from Fit for Frail. Now let's go to UP Wise Diliman. In Diliman, NSAIDs, non-steroidal anti-inflammatory drugs, were the most used drugs by the retired especially, followed by antihistamine and anti-hyperuricemic agents. So ang taas pala ng utility or use of NSAIDs in our retired Diliman participants. Now let's go to alternative treatments in Fit for Frail. I'm sorry I'm parang going between Fit for Frail and UP Wise, but remember we used the same questionnaire, and in fact we had the same geriatricians doing the assessments and the same laboratory providing the services. Okay, when we look at Fit for Frail and use of alternative therapies such as acupuncture, massage, or chelation therapy, this was 22%. So 22% used some sort of alternative therapy, more commonly by females and 70 to 79-year-old age group. Okay, using any alternative form of treatment was most common in the NCR, 32.1% in the NCR, and least common in Region 11, only 13.1% in the Davao region were using some form of alternative therapy as mentioned, okay? All right, we also realized that there was poor utilization of osteoporosis screening tests, specifically the DEXA scan, okay? And this is only from one study, We only asked this from the Fit for Frail study, and in that study, among our female participants, only 15.8% of them had bone density screening. Now remember, the Fit for Frail participants were outside of the Diliman community, and some of them had a lower belonged to a lower socioeconomic class. So maybe it was difficult for them to, even if they were asked to do a DEXA screen, it was probably difficult for them to comply with that request. Okay? All right. So yon, konti lang nagpapadexa screen. Okay, and then we also found out in that Fit for Frail study that there was a high fall risk because we did fall risk assessments. We did balance testing, we did the timed up and go, functional reach. We also did the JMAR, hand grip strength, and of course we asked them about a history of falling. And so there was a high fall risk, but only a low number reported their falls, that they had fallen. Only a few of them went to their doctors to say, oh, nahulog ako. And even if nahulog na sila, konti lang ang nagpakonsulta. Okay, so ito yon. Of the geriatric syndromes, again, geriatric syndromes are complex diagnoses. These are not usually reported or asked in regular researches, so this is very specific for this study. And if you see here, osteoporosis, okay, 54.8% had a high risk of falling. Ang taas, It was the most reported geriatric syndrome. while 1.7% reported osteoporosis, only 2% reported having a fracture, and 0.5% had poor balance. No? Pero meron din deconditioning, 0.3%. So this is just one way of looking at it. History of falling contributes to risk for falling, di ba? If you had a history of a fall, you are at high risk of another fall. So 30.9% of our participants fell in the past year. And this is not good because we know in geriatrics that after a fall within a year increases the risk of hospitalization and even death, no, among older people. But again, of those who fell, 30% lang ang nagpakonsulta, no? And those who fell were mostly about, well, of course, 70 to 79. But itong interesting dito, 76.5% of them had a fear of falling, especially among the very old and the female. Okay? All right. So let's now go again to the comprehensive geriatric assessment, because this was mentioned also by Up-to-Date. No? If you have an older patient with chronic back pain, you have to really have a more extensive assessment. So we looked at frailty. I know this is not part of the study, but nevertheless, I mean, not part of this talk, but it was part of our study. And we used a frailty screening tool. And frailty screening tools are usually sensitive and useful, huh? But they are of low specificity if it's just a checklist. But if you do a CGA or the comprehensive geriatric assessment, then your diagnostic accuracy for frailty becomes more accurate. Huh? All right, so we use this frailty criteria, which was adopted from Freed, and many of you who listen to some of my talks on frailty are familiar to this. So we had a score of the robust, pre-frail, and frail based on their score. No? And what we found out was in the Fit for Frail study, only 14.6% were frail. Most were pre-frail and 19.3 were actually robust, which is good. Right? And however, when we looked at the associations, no, frailty was associated with arthritis, okay, among other things. Other things, of course, were older age, poor nutritional status, risk of falling, but definitely arthritis was found out to be associated with frailty. Now let's go to UP Diliman and frailty. Ako, ang daming frail sa Diliman. Bakit kaya? So, in UP Diliman, 36.24% of them were frail. Hindi pa namin we were just thinking, bakit kaya mas madaming frail? Eh, mas madami naman nagpapa-check up, mas highly educated yung nagtatrabaho sa Diliman. Pero we were thinking, baka kasi most of them were doing office work, were inside classrooms, compared to those outside of Diliman, ang mga trabaho nila ay siguro mas mabigat at madaming opportunity for them to go around and walk, no? So maybe lang. That's just a hypothesis from us. So more people in the UP Wise Diliman were actually frail, with a little difference only between the retired and the working. And finally, because it was mentioned that you really have to ensure that older people have safe environments, fortunately, based on our Fit for Frail assessment, many of our participants reported that their environments were safe. So this was part of our study, and so they said that most of the hospitals and health centers that they went to had age-friendly features and had assistive devices, a fast lane, ramps, and lifts. And they felt safe also in their homes. Majority of them reported that their physical environment at home was well lit, well ventilated, free from slippery surfaces or uneven steps, and had their own space and room for privacy. So that's good to know. But I think, many of, we need to have more participants in future studies. Fortunately, we are funded for, and Dr. Corpuz, I hope you're still there. We are funded for another Fit for Frail this time. In Region 1, maybe we can visit, we can have a community in La Union as a Region 1 community to do Fit for Frail. and some communities in Region 3. So I hope that some of you from these regions will get in touch with me if you are willing to participate also and nominate your barangay in the next Fit for Frail study. So in summary, the experience of pain is not always confirmed on physical exam. Self-reported experience of arthritis underrepresents physician-diagnosed osteoarthritis. And osteoarthritis is still now one of the top 5 reported diagnoses. Drugs for musculoskeletal conditions are among the top 5, and it is top 3 actually when it comes to usage. And there is poor utilization of the bone density test as a screening test for osteoporosis. Many have a high fall risk, but only a few reported their falls and had a low consultation rate after a fall. We also learned that frailty is associated with osteoarthritis and that majority of the older participants in our studies reported living in safe environments, and many hospitals and health centers had age-friendly and safety features. So thank you so much. I hope you enjoyed that presentation, which complemented the presentation of Dr. Corpuz. If you need to get in touch with us, some of our lectures and slides are actually available in our YouTube and our Facebook pages. Thank you to the organizers. And my classmate, of course, Dr. Evelyn Salido, for inviting me, and Ma'am Pen. And of course, happy birthday to one of the founders of the Institute on Aging, in fact, Dr. Ting Amante. Happy birthday, sir.
Thank you very much to our speakers today, Sir Allan and Ma'am Shelley. Thank you very much for your very comprehensive lectures and very practical tips. Okay, so I think we had a few questions, but they're already answered in the chat box. But Sir Allan, I would like to just emphasize on the question earlier, no, on the fractures in the spine. They can be asymptomatic, and most of the time they are really asymptomatic. And for those who did not read your answer, can you please explain to us again what are the things that are the signs that we should be looking out for older adults?
Right. So for older adults, they will usually have an altered pain processing in the spine. So a lot of them will have very, very high tolerance to the pain. That's why even with multiple vertebral compression fractures, in the absence of actual nerve compression, they will probably have very, very minimal pain. So we need to watch out for the posture. If the caregivers would report loss in height, or if there's a kyphotic deformity, then these are indications for imaging. And for these patients also, it's very important to do densitometry to be able to establish the baseline bone density as we initiate treatment for osteoporosis.
Thank you, sir. Okay, so I have a question for the both of you, Paul. So how do you explain the concept of conservative management to our patients? Because sometimes there's a perception of a quick fix for musculoskeletal pain, and especially for our older adults. And sometimes it's very frustrating for both the care providers and the patients. So how do you go about explaining to the patients and their relatives the importance of conservative management? Ma'am Shelley.
Well, of course, they need to understand that first, as physicians, we need to understand that pain is real. We need to address pain. And then, of course, once you address that, you explain to them the reason why you are giving this kind of medication. No? Many times they are surprised, talaga, Tylenol lang ho, paracetamol lang ho,
Yeah.
Biogesic lang ho talaga. But we always have to explain that ito po ang pinaka-safe at pinaka-simple, pinaka-mura pati, no? But just try it. But of course, it's good to combine it kasi with other kinds of therapy, like if they have access to physical therapy, but maybe warm or cold compress, stretching, etc., and even just walking for simple osteoarthritis. You need to explain to them that we are considering the various medicines that they are taking and medical problems, no, that may affect our choice of therapy for them. It's not difficult talaga for them naman eh. It's not difficult for them to accept the kind of conservative treatment or management that we first provide them. Alan, how about you?
Yeah, I agree completely, Ma'am Shelley. No? So usually when you explain the disease condition to the patient and they understand fully the implications of the disease and what happens if you do not treat properly, then they will actually be very open to both the conservative treatment and the pharmaceutical management. Now, mostly mas maganda na nga na kino-combine yung dalawang yan so that parang yung conservative, yung initial na ni starts, especially if there are no red flags naman, and then proceed to the more intense therapy if the patient does not respond initially to the conservative management. Of course, for the inflammatory types of arthritis or back pain, you have to explain to your patient that delaying appropriate treatment could actually lead to more disabling disease. So it's just a matter of explaining or talking to your patient.
Yeah, so yung rapport talaga important, no, between us, the caregivers, the physical therapists, the nurses, and the patients. So, ma'am, in relation to that question on conservative management, it's very interesting to find out. No, thank you po for all the studies that you've presented to us first time. A lot has been taking alternative medicine in one cohort. So, do you also think that this cohort is also taking or making the most out of conservative management in terms of MSK disorders?
We did not study that. I mean, we did not really compare that cohort. We probably can look back at our data and see who among those taking this alternative medicine is also taking this kind of medicine and doing all of these stuff. We have not really analyzed it in depth, but we can do that. But I suppose, ang galing din ng marketing ng mga yan, supplements and food supplements in particular, no? Ang galing ng marketing nila, di ba? But it's difficult to find older people who are not taking food supplements now, no? Especially for arthritis. Parang sanay na silang uminom yan eh, di ba?
Yeah.
Same with massage din naman, di ba? Massage, very common yan.
Yeah. And I think so dapat mas magaling tayo mag-advertise what should be done in terms of non-pharmacologic and pharmacologic management.
Yeah. And I think, part of non-pharmacologic management is the avoidance of certain foods. Diba? Kung minsan, overly avoiding naman sila, diba? Kasi they have self-diagnosed themselves as having gout. And thank you for that book. So, ang dami kong pasyente na hindi po kayo gout. Pero hindi na talaga sila kumakain ng munggo, ibang mga gulay na healthy naman para sa kanila, di ba? So, yan.
Meron din po kaming booklet for that, specifically diet for gout. So, reach out to us. So, there's a question about chiropractors, no, in relation to us MSK geriatricians and rheumatologists. So, what do you think about this? Is it part of alternative medicine or conservative management? Sir Allan first.
I think there are some good quality evidence naman for chiropractors in terms of its use in spinal pain. So meron namang mga magagandang studies there. However, there are also some studies which have low quality evidence. So medyo mahirap pang mag-decide for now. But you see a lot of the clinical practice guidelines already incorporating the use of chiropractors in management of spinal pain. So I think there's a good body of evidence for this, and it's very promising also.
Yes, Ma'am Shelley, do you have experience with that with patients seeking
Yeah,
chiropractic?
I think it is a little bit expensive. Kaya only a specific group of patients, no, mostly the wealthier, I think, are able to afford chiropractic. Ano pang tawag doon? Chiropractor therapy. And many of them have been to the United States and have been exposed to that kind of treatment there. So konti pa lang. Of course, there are some warnings about chiro. Depende siguro sa sa level of skill ng chiropractor. That's the problem I think that we are encountering. Many probably are not skilled enough to deliver the safe care that we expect, no? compared to rehab and physical therapy. So there is a wider variation, I think, in terms of the skills of our chiropractors here.
Yeah.
That is also of concern.
Thank you so much to the one who posted that question. This question, Ma'am Shelley, I'd like to direct to you. So in some rural areas, some geriatricians are still, some geriatrics or older adults are still consuming some alcoholic beverages. So makakaapekto daw po ba ito sa osteoarthritis? And also, I'd like to pose that question to Sir Allan after.
Well, alam naman natin that when it comes to uric acid, the pathophysiology of uric acid, it can really adversely affect the level of uric acid in your blood if you consume a lot of alcohol. So yun ang nakikita ko. No, it really contributes to gout flares.
Yes.
But in terms of osteoarthritis, simple osteoarthritis, I would think that kung sobra ka ng lasing, baka ka mag-fall. O kaya baka inaantok ka na, wala ka nang masyadong ginagawa. Kaya sasakitin ng mga buto mo. So, nakakatuwang pag-aralan. Definitely, it also increases the risk of falling, which can lead to injury and therefore arthritis and other bone and joint problems. But mostly, I think it affects gouty flares.
Yeah, I agree with Ma'am Shelley. No? So yung sa alcohol, it directly affects gout. So it has a high correlation with gouty arthritis. But for osteoarthritis, maybe indirectly, because if a patient will have recurrent gouty flares, then they can also develop a secondary osteoarthritis because of recurrent swelling of the knee, for example, or the ankle. So nagkakaroon din ng damage yung joint when it's recurrently being affected by gout. And of course, because of being drunk, you can suffer fractures, trauma to the back, to the joint. So pwede din na mag-trigger ng eventual osteoarthritis yon, but not really primarily.
Yes, I agree. So actually, even beyond osteoarthritis, even osteoporosis, alcoholism, or alcoholic intake is a risk factor for decreased bone density. So
osteoporosis, you're right.
Okay, so Sir Allan, I have a question. So toxicity in treatment. So please explain more of the science of toxicity. I think maybe NSAIDs, no? NSAIDs is more appropriate drugs to be talking about.
Right. So when we talk about NSAIDs, of course, there are two major toxicities that we have to look into, and that's gastrointestinal toxicity and renal toxicity. And another one would be cardiac toxicity. So usually for elderly patients, we would like to avoid the traditional NSAIDs because they have a higher risk of causing gastrointestinal bleeding. Most of the patients also who have arthritis have been taking NSAIDs for a long period of time, and perhaps a lot of them would already have chronic kidney disease at this stage in their lives. So we also have to be careful with that. That's why I emphasized a while ago in the talk that we need to establish the baseline renal and hepatic function at the start of treatment. So we should not be prescribing NSAIDs left and right. And again, for cardiac toxicity, we should evaluate the presence of heart failure, hypertension, as these disease conditions can be worsened with chronic intake of NSAIDs. Yung iba naman, yung mga pregabalin, duloxetine, we have to be careful because for elderly patients, they are prone to have behavioral changes, hallucinations. They're prone to experiencing decreased levels of consciousness, prolonged sleep. They have nausea and vomiting. So these are the things that you need to watch out for when using these medications. For opioids, we want to see if may possibility ng opioid dependence. Lalong-lalo na yung mga nasanay na umiinom ng tramadol for very long periods. After a while, even without pain, they're going to start taking the medication just because they're addicted to it.
Yes. So,
yeah, and let me just share a story.
Yes,
we had a patient who had severe arthritis, who needed knee surgery na talaga. But he really was opioid dependent. In fact, his presentation to us was acute ill use. And so they referred the patient for gastrointestinal workup and all, na colonoscopy and all, only to learn later on, ang taas pala ng opioid use niya. No?
Yeah.
So let's be aware of that. One thing that was not emphasized as much and is that as those who are 50 and older, who are office workers, di ba? Parang related to sa study ko eh. dapat talaga we are aware of ergonomics. So we need to have better ergonomics where we work. And of course, to ensure that we have exercise and fitness programs where we work. Kasi pagtanda natin, habang ngayon pa lang nga, sumasakit ang mga likod natin, kaka-zoom natin, di ba? Let's be aware of that aspect also of care. Huh? Fitness and ergonomics.
Thank you. Thank you so much, ma'am. Okay, so I think for the interest of time, I'd like to ask two more questions for both of our lecturers. Ma'am Shelley, this is interesting because you presented the data on vitamin D deficiency. So, would you consider nutritional deficiency among Filipinos, especially the elderly, as a prime cause of osteoarthritis, or maybe a prime cause of other MSK disorders?
Yeah, I think the low vitamin D in that cohort needs to be studied further because in the other communities that we went to, hindi naman ganun kataas ang vitamin D deficiency. So there must be something about that cohort alone. So I cannot make that conclusion at the moment. But definitely, especially during the COVID pandemic, there was a lot of excess use din of vitamin D. Nag-overdose nga yung iba kong mga pasyente. So, but only my response there is we need to study that further. Definitely, it is associated with osteoporosis, but osteoarthritis alone and other inflammatory joint pains, I think that has to be studied further.
Yes, actually in my private practice, significant din talaga yung rate of vitamin D deficiency, and think na we are the tropical country. So there must be something weird.
Always indoors daw kasi eh.
Sorry, yes.
Sobrang init, so nasa loob tayo lang.
And we use payong when we go out. Even if
Tama, isa pa yan. Nagsa-sunscreen pa, di ba?
yes. Okay, Sir Allan, I think last question for you. Do you have experience? Someone is asking about PRP injections. So in osteoarthritis.
I don't personally do it, but I think the evidence is already building regarding PRP. So the problem with PRP studies kasi it's very heterogeneous. Iba-iba yung mga standards na ginagawa per institution or per medical practitioner. So if you look at the studies, iba-iba siya. That's why it's very hard to generate a robust conclusion. But I think we're about to get there. But for me personally, I don't use it. I recommend it for my patients with bursitis or tendinitis. For osteoarthritis, I think it might have benefit for the early stages, but for Kellgren 3 and 4, perhaps di na masyado.
Yeah, agree. Right. I'm sorry, but this is a very important question. So last na ma'am. Ma'am Shelley, how does aging contribute to the development and progression of rheumatic diseases in the elderly population?
Rheumatic diseases. Well, of course, there is a change in the bone metabolism, for example, that leads to degenerative conditions, including osteoporosis. We know that as being part of the aging process. Inflammation, of course, is also part of it. Diet is also probably affected by aging because there are now certain nutrients that may be deficient in their diet as they age. Hindi makanguya masyado.
Yeah.
But what I'm noticing in some of my patients is that there is really a cohort that never took milk when they were young. So hindi talaga, maybe it was because in where they live there was no kalabaw or baka, and these now are the cohort that are more prone to osteoporosis. But I think in the aging process itself, aside from just the physiology of aging that contributes to rheumatic diseases, there also has to be a supportive environment that allows an aging person to mobilize more efficiently and effectively. Walking spaces, for example. Do we have that for our old people to exercise and to walk? And do we provide a safe environment for them? So there are other questions beyond just the physiology of aging. Another thing is, of course, there are broad disease states that as you age, you are exposed to. And these diseases can contribute eventually to the development of osteoarthritic conditions as you age. No? There are infections, of course, accidents and disasters happen throughout life. So it's really beyond just the plain and simple physiology of it.
Thank you very much. Sir
You're
Alad, I'm sorry, last question for you. Are there notable differences in response to pharmacologic interventions for rheumatic diseases between younger and older patient populations?
Yes, of course. Because for the older population, they will mostly have a lot of comorbid conditions. They will have renal problems, cardiac problems. They can have hepatic problems, and this can affect the way that drugs are metabolized in the body. So there's probably a big difference between the very, very young, so yung mga pediatric patients, and the very old, and those who are in the middle-aged population. And that is because of metabolism of the medications. Also, compliance would play a role here. The elderly patients, in the absence of a dedicated caregiver, may find it hard to follow yung instructions when you prescribe a medication. In contrast to somebody who's younger, who's able to understand the diseases. Sometimes nga nami-mix up nila yan eh. Nate-take nila ng mas madami yung isang tablet rather than the other tablet just because they cannot remember, or they cannot correlate what you wrote down to what they're about to take. So
Yeah. Thank you very much. So again, thank you very much for everyone who attended, and I hope we have a lot more time to discuss about this because it's very important to us right now, to our relatives, our grandmothers, or grandfathers. And to summarize today's lecture, we have discussed that the possible causes of back pain or joint pains in the 50-plus-year-olds and the red flags that we should be aware of. And we also learned that without the presence of these red flags, imaging is usually not indicated within 6 weeks. It is also important to remember that in non-inflammatory MSK diseases in the 50s and above, it is best treated with both non-pharmacologic and pharmacologic management. So we also have been presented with new data hot off the press about the experience of both older adults as well as their clinicians in dealing with osteoarthritis. And patient-reported osteoarthritis we found out that it's actually lower than the geriatrician diagnosed osteoarthritis, which probably means that we should strengthen our educational management for our patients. And from one of the cohorts, Ma'am Shelley discussed a lot about taking drugs for musculoskeletal pain. And I hope that the non-pharmacologic or the conservative management is also being utilized. We also found out that frailty in one of the cohorts is really prevalent. And I think this is an opportunity for all of us to explore the risk factors because a lot of our older relatives fit in this population. Okay, so again, that concludes our webinar, the finale of LMLR 2023. Thank you so much to our experts today. Very comprehensive lectures and discussion. Thank you to all our audience for the interesting questions. And please be reminded that the link for the evaluation form is posted in the chat box. To avoid any inconvenience in your certificate of attendance, please type in your complete name and correct email address where you want your certificates to be sent. We would like to thank the Information Management Service Network team of UP Manila and our sponsor, Viatris. Thank you all for joining us again as we end the last part of our webinar series for LMLR 2023. We hope to see you all next year in the LMLR 2024 for yet another set of informative and interesting lectures in the field of rheumatology. 31 days left before Christmas, everyone. In behalf of the Division of Rheumatology of UPPGH, happy holidays and have a great afternoon. Thank you.